Hello and welcome again. My next video aims to illustrate that sometimes in Barrett's esophagus, neoplastic areas can be very obvious because of the size of it, the extent of it, and the big nodular nature of it, as was in this patient. My next patient was discovered to have neoplasia by a referring endoscopist who thought he had found a cancer in a patient with Barrett's esophagus. So the patient had biopsies taken and referred via our MDT for radical surgery. But they were very surprised when the biopsies came back showing only dysplasia, and that's when the patient was referred to me. I then repeated the endoscopy, and I have to say that on white light endoscopy, when I first saw the lesion, my first impression was also that this is likely to be cancer. However, the surface pattern of the lesion, when assessed with acetic acid and zoom endoscope, was very reassuring. And my thoughts then were that this looks like nodular dysplasia rather than an invasive cancer, and it would be safe to proceed with EMR rather than surgery. I hope you enjoy the video, and I'll get back to you about the EMR technique after you've seen the video. Thank you. Hello and welcome again. Now that you've already seen the video and the extent of lesion, I feel some of you might be wondering why we went for an endoscopic approach in this lesion. It was big, it was extensive, and in a very big segment of Barrett's. And I'm sure a lot of you would be wondering that the surgery would have been the better option here. However, we decided against that, and the reason for that is because when I assessed this lesion using advanced endoscopic imaging technique, I was confident of the non-invasive nature of this lesion. I could see the complete extent of this lesion and could accurately mark its borders, and I also knew that the lesion was involving less than half the circumference of the esophagus. And all these factors pushed me towards endoscopic approach rather than a radical surgical approach. Now you must have seen that during EMR I've used a combination of two different techniques, as I've started with injection, lifting and using a cap and snare technique, because I feel that when you have a very nodular lesion, the risk of invasive cancer remains higher than the flat dysplastic lesions. So I always inject and confirm the lifting sign and then resect all the nodular bits using the cap and snare technique, and then following that I use the duet or the bending technique in this case to remove all the flat dysplastic area. And we finally achieved an extensive but a complete EMR of the dysplastic area in this case, and I'm pleased to inform you that the whole lesion came back as high-grade dysplasia with no evidence of invasive cancer. So it was an overall happy ending. Thank you.